Assalamualaikum. I'm Dr. Sadia Idrees, consultant obstetrician and gynecologist, and today I'm again here with another high lecture about assisted vaginal birth, labor module, lecture number 3 and part B. Before we start, Bismillahir Rahmanir Rahim, in the name of Allah, the most gracious, the most merciful. And in this lecture, we are going to discuss the indications, the methods, the technique, the complications, the management. So, in yesterday's lecture, we ended on some important points like the clinical assessment and preparation of the prerequisites. We should confirm the full dilatation and ruptured membranes. And ultrasound is better than clinical examination for fetal head position, but not recommended. Routinely obtain verbal consent in labor, written consent for OT trial of assisted vaginal birth, and always have a backup plan for emergency C-section. So, before we talk about forceps and vacuum, let's answer one very important question. Who should perform an assisted vaginal birth? According to RCOG, there's a grade D recommendation. The most important factor is not the instrument operator, it is the operator. The doctor performing the procedure should have 4 things. First, good clinical knowledge. They should know when instrumental delivery is indicated and when it is contraindicated. Second, the technical skills. Knowing the theory is not enough. You must know how to apply the instrument correctly. Third, sufficient experience. The more cases you perform under supervision, the safer you become. And finally, the ability to recognize and manage the complication if something goes wrong. Think about it this way: give a Formula One racing car to someone who has never driven it before, they still cannot win the race. Similarly, even the best instrument cannot give good results if the operator is not competent. So always remember this key message that safe instrumental delivery depends more on the operator than on the instrument. Am I clear so far? Okay. So complex assisted vaginal birth. Now let's move one step further. Not every instrumental delivery is simple. Some cases are called the complex assisted vaginal birth. What does this complex mean? Assisted vaginal birth that are more difficult and have higher risk of complication or failure. It means the delivery is more difficult and carries a high risk of failure complication. Common examples include mid-pelvic birth, mid-pelvic delivery, and rotational instrumental delivery, where the baby's head need to be rotated before birth. So, who should perform these difficult procedures? Again, the RCOG is very clear. These deliveries should be performed only by an experienced operator or under the direct supervision of an experienced consultant. Why is this so important? Because an experienced doctor can recognize the problems early, improve the safety of both the mother and the baby, and if the delivery is not progressing, make a timely decision to perform a cesarean section. So never tap a difficult instrumental delivery alone if you don't have the required experience. The patients are not to play. And always remember, every complex instrumental delivery should have a backup plan for emergency cesarean section. Am I clear so far? So, where should assisted vaginal birth take place? Now, the next question this is. The answer depends on the level of difficulty. If it is a low risk procedure, such as non-rotational low pelvic delivery or a lift out outlet delivery, it can usually perform safely in the labor room. But what if the procedure is more difficult? If there is a high risk of failure, or if it is a mid-pelvic delivery, or if a rotational delivery is required, then the procedure should be performed in a operation theater. Why? Because if the instrumental delivery fails, you may need an emergency cesarean section, and every minute is important. For example, imagine you are attempting a rotational forceps delivery in the labor room. If it fails, you now have to ship the patient to OT. During this delay, the baby may become more compromised. That's why high-risk instrumental deliveries should start in the operation theater. So, the golden rule is choose the right place according to the level of risk and always have a backup cesarean section plan. Also, when the instrument you're applying is in labor room, you should have a verbal consent. And if you're applying in the OT, then you should have a written consent. Am I clear so far? Okay. Now, the factors associated with high failure rate. Now, before attempting any instrumental delivery, ask yourself one important question. Will this procedure succeed, or is there a chance of failure? Certain factors significantly increase the likelihood of a failed assisted vaginal birth. Let's go through them one by one. First, maternal obesity. BMI more than 30. Obesity can make assessment of fetal station and instrument application more difficult. Second, short maternal stature, which may be associated with a relatively smaller pelvis. Third, an estimated fetal weight of more than 4 kg. A larger baby means more resistance during delivery and a greater chance of failure. Fourth, a fetal head circumference more than 95th centile, making descent through the birth canal more difficult. Fifth, occipito-posterior position. OP babies often require rotation and are technically more challenging. And finally, mid-pelvic birth, that is, the head is more than 1/5 of the fetal head is still palpable abdominally. These cases require greater expertise and have a high failure rate. The most important point is this. These factors are not absolute contraindication to assisted vaginal birth, but they should make you pause and plan carefully that whether the patient have a high risk of failure or not, and whether it will succeed or not. It comes in patient safety. They help you decide whether senior supervision is needed, whether the procedure should be done in the operation theater, and whether cesarean section may be a safer option. Remember the example. Higher risk of failure means better planning, better supervision, and always have a backup plan. So let's quickly revise the most important point from this section. First of all, number one, never perform instrumental delivery independently. Competency is very important. Until you have achieved competency in the clinical knowledge, technical skills, expertise, and ability to manage the complications. Secondly, simulation training and supervised clinical practice are essential before independent practice. Number three, mid-pelvic and rotational instrumental delivery should only be performed by experienced operator or under direct senior supervision. Do not play with patient, please. Number four, low risk outlet and low pelvic non-rotational deliveries can usually be performed safely in the labor room. Number five, high risk or potentially difficult instrumental delivery should be attempted in the operation theater with immediate cesarean sections available if needed. So remember the golden rule: safe mother, safe baby. Right place, right team, and always have a backup plan. If you remember these five first, you will answer most 500 exam questions confidently. Okay. Now comes one of the most commonly asked examination questions. Should we use forceps or vacuum? So according to RCOG, this is a grade A recommendation. The answer is simple. There is no universally best instrument. The choice should always be individualized according to the clinical situation. There are four major factors to consider. First, the clinical circumstances, including the fetal station, the position, the stage of the labor, maternal pelvis, and adequacy of anesthesia. Second, the fetal condition, such as fetal size, the lie, the position, the head attitude, and overall fetal well-being. The third, the maternal condition, including the parity, previous perineal trauma, maternal exhaustion, and any significant medical comorbidities. And finally, the operator's skill and experience. Even the best instrument can become unsafe if the operator is unfamiliar with its use. Don't ask which instrument is best. Instead, ask which instrument is safest for this patient in these circumstances and in my hands. This is exactly what the examiner wants to hear. And it is also the key principle of the safe obstetric practice. Now, let's compare the two most commonly used instruments in the assisted vaginal birth, vacuum and forceps. Forget about it, it's like a parachute mask. Okay, according to RCOG grade recommendation, neither instrument is universally superior, as I told you. Each has its own advantages and disadvantages. Let's start with vacuum. The biggest advantage of vacuum is that it causes less maternal trauma. It is mother-friendly, fewer severe perineal injury. However, the trade-off is a high failure rate. If the vacuum fails, another instrument or cesarean section may be required more often. Now, look at the forceps. Forceps provides more better traction and therefore have a higher chance of achieving a successful vaginal birth, especially in difficult deliveries. The disadvantage is that forceps are associated with more perineal trauma, including high risk of obstetric anal sphincter injuries. So remember this simple example: vacuum fails more often while forceps injure the mother more. The single sentence summarizes the difference and is frequently asked in viva examination. Vacuum is mother friendly, and forceps is baby friendly. Now, soft cup vacuum versus rigid cup. Not all vacuum cups are the same. There are two main cups, soft cup and rigid cup. A soft cup is usually made of silicone. It is more flexible and conforms to better to the fetal head. Its major advantage is that it's less neonatal scalp trauma. However, because its grip is weaker, it has a high failure rate and is more likely to detach during traction. In contrast, the rigid cup, usually made of metal, it provides better traction and therefore has a higher success rate, especially in more difficult deliveries. The downside is a greater risk of scalp injuries, such as scalp laceration or sepal hematoma. So the key message is very easy to remember: soft cup, safer for the scalp, but more failures; rigid cup, stronger traction and higher success, but more scalp trauma. Choice depends on clinical situation and the operator experience. But nowadays the soft cup is preferred. Now, let's discuss rotational instrumental birth, one of the most challenging areas of the operative obstetrics. And according to the RCOG graded recommendation, rotational instrumental delivery should only perform by experienced operator. There are four accepted approaches. First, Kylan rotational forceps. These are specifically designed to rotate and deliver the fetal head in a single procedure and require considerable expertise. Second, manual rotation followed by direct traction forceps. The fetal is rotated manually to occipital anterior position followed by forceps delivery. I'm sharing my experience. I just did this manual rotation last week, and believe me, that patient was in severe pain and she was taking trial for some dye, and she came to me and I just did manual rotation and the head delivered so beautifully. If you know these skills, believe me, it is life-saving for the baby and the mother instead of doing abdominal delivery. I heard someone saying that one of my seniors, a safe obstetrician is not the one who delivers the baby via the cesarean section. It's the one who also knows how to deliver the baby safely vaginally as well. It's not what buddy thing that you deliver the baby abdominally. You should know at least how to deliver the baby beautifully and safely vaginally as well. Okay. Third, manual rotation followed by vacuum extraction. Again, the head is first manually rotated and then a vacuum cup is applied for the delivery. Finally, rotational vacuum extraction, where the vacuum cup is used while allowing control rotational movements during traction. The important thing is that there's no single best technique. The choice depends on the operator's expertise. Again and again, I'm saying this in operators' expertise, the clinical situation, and the resources that are available. If you are not experienced in rotational instrumental delivery, don't persist. Seek senior help early or proceed to citizen section if needed. Always remember, the safest delivery is the one performed by the right operator at the right time using the right technique. Don't play with patient. They are not toys. Okay. Now, instrumental birth outcomes comparison. It is done in this slide. Now, let's compare the maternal and neonatal outcomes of vacuum and forceps. Maternal outcomes starting with vacuum extraction. Vacuum is associated with less maternal trauma overall. As I told you, episiotomy is required in around 50 to 60% of cases. Severe perineal tears approximately in 10%, while obstetric anal sphincter injuries or OSS occur in only 1 to 4%. PPH or postpartum hemorrhage occurs in about 10 to 40%. Some women experience temporary urinary or bowel symptom. Now compare this with forceps. Episiotomy is required in more than 90% of women. Severe perineal tears occur in approximately 20%, while OBS and sphincter injury increases to around 8 to 12%. The risk of PPH or postpartum hemorrhage is similar, but severe perineal injury is clearly higher with forceps. Forceps means more maternal trauma. With vacuum, the common neonatal complications are cephalomatoma in 1 to 12%, subgluteal hemorrhage, which is rare but potentially life-threatening, retinal hemorrhages, scalp or facial laceration, and in forceps, but neonatal complications are different. These include facial appendice, which is rare, skull fractures rare, facial injuries, and rare intracranial hemorrhage. Remember, forceps causes more maternal trauma, whereas vacuum causes more scalp-related neonatal injuries. However, when used correctly by trained and experienced operator again and again, both instruments are generally safe and effective. Let's finish this again with two important exam updates. First, Kylan forceps. Kyle forceps have a high success rate, 90 to 95%, particularly for rotational deliveries, lower failure than rotational vacuum, and reduce the need for sequential instrumentation. However, these forceps should use an experienced operator. They're not suitable for beginners because incorrect use can result in significant maternal and fetal complication. Now, the Udon device. It is a new low-cost assisted vaginal birth device designed to facilitate delivery using an inflatable sleeve around the fetal head. It is a new low-cost assisted vaginal birth device designed to facilitate delivery using an inflatable, you can see that, sleeve around the fetal head. It has attracted considerable interest because it may simplify assisted vaginal birth, especially in low-resource setting. However, at present, WHO is still evaluating its safety and effectiveness. Therefore, it is not recommended for routine clinical practice outside the research setting. So remember, the current forceps are highly effective, but required expertise, and the Udon device is promising, but it remains investigational and is not yet part of routine obstetric practice. So again, we have completed the core principles of assisted vaginal birth. Again, we have to revise that always choose an instrument according to the clinical situation and the operator expertise. And vacuum causes less maternal trauma. It has high failure rate. Forces achieve a high success rate, but they're associated with more perineal injury. And soft vacuum cup causes less neonatal scalp trauma, but they fail more often than the rigid cup. Kylan forceps should only be used by experienced operator, and the Udon device is still investigational and not recommended for routine use. The single most important message from this guideline is there's no universally best instrument. The best instrument, the one selected for the right patient, but the right operator at the right time. So always remember the golden rule: skill plus judgment plus experience is safe delivery. Now, when should be vacuum birth be discontinued? One of the most important principles in assisted vaginal birth is knowing when to stop. When to stop. The RCOG clearly states that vacuum extraction should be discontinued if there's no progressive descent with moderate traction. If the cup is correctly applied, but head does not descend, do not continue pulling with greater force. Instead, stop the procedure and perform a complete clinical reassessment. Reevaluate the fetal position, station, cup placement, and look for possible cephalopelvic disproportion or any other reason for failure. Remember, persistence with the failure in vacuum delivery only increases maternal and neonatal complication. No descent means stop traction, not pull harder. Recognizing failure early is a sign of good obstetric judgment. It does not mean that you have failed. So, to improve safety, remember the vacuum 3+3 rule. The first 3 traction pull should be enough to bring the fetal head onto the perineum. Once the head reaches the perineum, up to 3 gentle pulls should complete the delivery of the head. If more than this is required, you should pause, reassess the situation, and reconsider the procedure. Do not continue repeated unsuccessful traction simply because the baby is almost delivered. The 3+3 rule is a practical safety guide, not an absolute law, but exceeding it should be always prompt reassessment and reconsideration of an alternative plan. Now let's discuss 2 important warning signs during vacuum extraction. First, poor progress. If there's minimal or no descent after the first 2 traction pulls, stop and ask yourself why. Possible reasons include incorrect cup placement, incorrect diagnosis of the fetal position, cephalopelvic disproportion. At this point, perform a careful clinical reassessment, seek senior review, and decide whether to continue or change the management plan. Second, cup pop-off, or detachment. If the cup detaches repeatedly, this is an important warning sign. According to RCOG guideline, vacuum extraction should be abandoned after 2 cup detachments or pop-offs. For junior operator, senior help should be sought immediately after the first pop-off. Repeated cup detachments increase the risk of neonatal scalp injury while reducing the likelihood of successful vaginal birth. Repeated pop-offs are not a reason to keep trying and trying. They're a reason to stop and reassess the situation and choose a safer alternative for the mother and the baby. Now, let's finish the technical aspects of the vacuum delivery. Current RCOG recommendation recommends rapid creation of the negative pressure because rather than slowly increasing suction, rapid vacuum application shortens the procedure without increasing maternal or neonatal complications, making the delivery more efficient. And now an important exam point, sequential instrument. This means using vacuum followed by forceps or forceps followed by vacuum. Sequential use is associated with increased neonatal trauma, increased obstetric and sphincter injury, and higher maternal morbidity. So avoid whenever possible. If one instrument fails, don't automatically switch to another. Stop, reassess, seek senior help, and consider C-section appropriate. See, if vacuum fails, you can go for forceps. But if forceps fails, go for cesarean section. Go for cesarean section. Okay. Whenever a vacuum delivery has failed, your responsibility does not end with stopping the procedure. The neonatologist should be informed immediately, especially if there have been multiple pulls or cup detachments. The newborn should be carefully monitored for subgleal hemorrhage, intracranial hemorrhage, scalp trauma, other neonatal injuries. Early recognition can be life-saving because subgleal hemorrhage may initially appear supple, but can rapidly become catastrophic. So every failed vacuum delivery deserves a careful neonatal assessment, even if the baby initially appears well. Just like vacuum extraction, forceps delivery also has clear stopping rules. Forceps should be abundant if the blades cannot be applied easily, handles fail to articulate or approximate properly, no progressive descent despite moderate traction, rotation cannot be achieved easily during rotational forceps delivery, and birth is not imminent after the 3 traction pull. Never use excessive force simply to complete the delivery. Remember the forceps 3 pull rule. If effective descent is not occurring, stop, reassess, and consider an alternative plan. If forceps delivery fails, immediately reassess the situation. Minimal descent after the first or second pull should make you think of incorrect application, wrong or incorrect fetal position, or cephalopelvic disproportion. The next steps are straightforward. Reassess the situation, call for senior help. There's no shame in asking for senior help in case of patient safety. Decide whether to abandon the procedure. If cesarean section becomes necessary, be prepared for an impacted fetal head and use recognized fetal head disinfection techniques. Don't forget to inform the neonatologist following a failed instrumental birth. The priority is safe delivery, not successful completion of the instrumental procedure. Am I clear so far? So let's finish with the most important exam point. Stop vacuum if there's no descent or 2 pop-offs. Remember the vacuum 3+3 rule. Remember the forceps generally follow the 3 pull rule. Poor progress should always make you think of cephalopelvic disproportion, malposition, or incorrect application. Avoid sequential instrument whenever possible because they increase maternal and neonatal morbidity. And after any failed instrumental birth, reassess the mother, call the senior help, and inform the neonatology team. Assisted vaginal birth is not about strength. It is about judgment. The safest operator is not the one who never stops, but the one who knows when to stop. Skill plus good judgment plus timely decision is means safe mother, safe baby. I think this summarizes all the things that I told. Before we finish, let's quickly revise the most important points. Again, just a short recap so that first of all, assisted vaginal birth should only be performed by a competent trained operator with appropriate knowledge, technical skills, experience, and the ability to manage the complication. Complex instrumental birth, such as mid-pelvic and rotational deliveries, should only be performed by experienced operator or under direct supervision. Low risk and low pelvic deliveries can only be performed safely in the labor room, whereas high risk, rotational, or potential difficult deliveries should be attempted in operation theater with facilities for immediate cesarean section. Instrument choice should always be individualized. There's no universally superior instrument. Vacuum causes less maternal trauma and has a high failure rate. Forceps have high success rate but associated more maternal perineal in trauma. Soft cup reduces scalp trauma but fail more often than the rigid cup. Current forceps should only be used by experienced operator. The Odon device remains investigational and is not recommended for routine practice. And you should know that when to stop. You should know that in vacuum, if there's no descent to cup detachment or reassessment suggests failure. Remember the 3+3 rule. When forceps, follow the 3+3 rule, pull rule, and abandon the procedure if the progress is inadequate. Avoid the sequential instruments because increased maternal neonatal complication after any failed instrumental birth. Reassess the mother, involve the senior help, inform the neonatologist, and monitor the newborn carefully. That brings us to the end of the today's lecture, assisted vaginal birth. I think it is more than enough. You will be overwhelmed. Tomorrow we are again going to scan after vacuum delivery, after the post-traumatic stress disorder, the thromoprophylaxis and episiotomy, and some brainstorming single best answer. So remember, that success in your exam does not come from memorizing the fact. It comes from understanding why you make each clinical decision. So whenever we are in the labor room, you should always think like a safe obstetrician. You should know what the guidelines recommend. If you found this lecture helpful, please like, share, and subscribe to the channel so you don't miss the upcoming lectures. And if any questions or topics you'd like me to cover next, let me know in the comments. And thank you so much for watching. Until next time, stay evidence-based, stay confident. Always remember, right patient, right instrument, right operator, right time. Safe mother, safe baby. Thank you so much.